Good morning, my name is Jo Newton and I'm Chair of Black Country Partnership Foundation Trust. And I'm here to introduce you to Merit. We cover a combined population of 3.5 million in the West Midlands Combined Authority. If I can just introduce my colleagues, we've got Mark Axel, who is Acting Chief Executive and Director of Finance at Dudley and Walsall Trust. We have John Short, who is Chief Executive of Birmingham and Solihull Mental Health Foundation Trust, and we've got Sharon Binion, who is the Medical Director of Coventry and Warwickshire Partnership Trust. So why Merit? In 2013, a young man called Philip got on the number 9 bus in central Birmingham, and in an unprovoked attack, he stabbed a schoolgirl called Christina Edkins. He was later convicted of manslaughter on the grounds of diminished responsibility. The inquest concluded that despite contact with 7 agencies across the NHS and the rest of the public sector, a firm diagnosis had not been able to be reached. And this was in part due to the fact that information sharing and knowledge had not been widely available. We know that vulnerable people live in our communities. We already reach out and are part of their lives and supporting them in the communities. And we respond to them in crisis, but we know that we could do better. We know that this year, more than 1 million patients will turn up at A&E with a mental health crisis. And in June, we know that the CQC reported that actually the experience of patients with crisis at A&E could have been better. We believe that we must fit in with people's lives rather than ask them to fit in with our services. And this is Merit. This is what we want to do by providing a consistent service across our population of 3.5 million, 7 days a week for those in crisis and through to recovery. To help build parity of esteem, reduce those health inequalities, and help reduce the work that turns up in some of your A&E units. And this is how.
Thank you. We are a unique alliance of 4 mental health trusts who work predominantly in the community. 97% of our patients are treated in the community, and we cover a population of 3.4 million. Our model depends upon us developing consistent shared care pathways focused on measurable patient outcomes, which will be across the patch. Let's, for example, take the example of a 19-year-old girl called Aisha. She lives in Wolverhampton. She goes on the train to Birmingham, and in Birmingham she's picked up by the police behaving strangely. Aisha is starting to suffer from psychosis. In the past, she would have been taken to a police station, and some considerable amount of time would have elapsed before Aisha received treatment, sometimes days. Under our new proposed system, we will have a shared pathway, starting with street triage, working with our police partners, where Aisha will be assessed and taken to the appropriate assessment unit and moved into treatment in Wolverhampton within hours. The team will know what the care pathway is, and Aisha will not need to retell her story many times to professionals. By having a shared care record, all of the information will be there for people to see. Take another example, Terry. Terry is 49, his wife's left him, he's drinking too much, he's a bit depressed, and he takes a significant overdose. He could emerge in any of the 12 acute trusts that are covered by our patch. By having a consistent liaison response based upon the innovative RAID model developed in Birmingham, Terry will have a consistent care pathway and will be able to move into treatment quickly. Where that treatment requires admission, that admission will be found. And because we will be running a consistent 7-day service across the patch, he will be able to have a consultant opinion within 24 hours. Other areas we might work on are research and innovation and scaling up our pilots at speed and pace in the different organisations, And also through our workforce. We will be able to broker workforce training because we will know the workforce needs across the care pathways. We will be able to make sure our workforce can move flexibly between organisations. We'll be able to address the issues of our 30 million collective spend on agency by having a shared approach to bank and agency usage. As you can see, this is a relatively new project, and we believe that the vanguard status will give us the impetus and the experience to help us to get this off the ground. We will have exec-level steering groups, there'll be a clinical forum, and the work streams will be clinically led with appropriate user and carer input from our user and carer projects in our respective organisations. If we can achieve this, for the patients, they will experience consistent care across the 4 organisations and will not need to understand the boundaries between our services. Our workforce will have consistent training and ability to move between organisations, and our partner organisations, the police, ambulance and you as Acute Trust will know exactly what you can expect from us as a mental health organisation.
So, colleagues, with Merit, we offer a unique new care model where, for the first time, we can offer that seamless service in mental care to provide a better service for our patients and their carers. We will try and address the 7-day working issue by working with staff to build resilience. And we believe we can create a template adaptable for use by other mental health and community providers to in-reach acute services and to support our partner agencies. We believe we'll also benefit the taxpayer, since along with efficiency gains, better recovery offers the chance for employment. And most of all, we feel we'll be able to keep our promise to Christina's parents that incident on that number 9 bus will not be able to happen again. So we may be Merit, but we hope with the support of the Vanguard process, we will be able to be distinction. Thank you.
Thank you very much. Can I have questions for the Mental Health Alliance, please? Down here, table number 5.
Thank you so much. That was a really interesting presentation. Wonderful to hear your plans. I'm interested to know a little bit about what you're doing together already and whether you could just bring that to life for us.
One of the things we already do together is we actually have a learning and education training council specifically for mental health, and we can demonstrate that we already work together really well. We were asked earlier today about, are we the finished model? We're not. This is a real attempt to come together. We represent as a huge patch and population that we cover. And interestingly, compared with a number of the other networks you've heard today, mental health has never been encouraged to work together. And actually, the issue of consistency is absolutely awful in our services. So you can cross the boundary from one mental health service to another one, and you receive a completely different service. So what we're aiming to do here is build on the bits that we've already to do very well together, which is about education and some of the training areas, but really try and provide a truly consistent approach. So if RAID is right, if 24-hour support is right in an emergency department, why is it available in Birmingham and not in Dudley? And we want to make it available across the whole patch.
Thank you. Question on table number 15.
Yes, Gordon Kearns again, a service user from Cheshire. I'm worried about the street triage service. We've had a street triage service in Cheshire, and it's had to be stopped because the funding wasn't available. Is the funding available for yours if you don't get the Vanguard?
Okay, thank you. Yeah, we do have street triage across all of our 4 organisations. And just to pick up on that point, what I don't think we've ever done in the past, because we've not been encouraged to do, is actually look at how it works across the whole system. So we all get individual amounts of funding to deliver that system, but we don't look at it to say, how is it most efficient, what is best practice for patients, and how can we drive some funding and efficiency out of that to actually sustain the model. So yes, I agree with your statement about how do we secure the funding, but we believe in the inconsistencies in the way care is provided and some of the patient stories that you've just heard, that we can actually drive some money out of it to actually continue to fund the model.
So I hand table number 25, please. 26.
Julie Tasker from Nottinghamshire, patient representative. Why are we having to wait until people are in crisis?
We're not, and if we'd had longer to actually explain our presentation, we've got some very exciting work we want to do in relation to recovery and preventive support, but actually trying to pitch to our audience today, one of the things that we can make the biggest difference on is actually crisis and urgent care. And we've seen in Birmingham and the Black Country over the last 2 or 3 years, huge strides made forward in terms of keeping people out of police stations and providing better urgent care, and have genuinely been frustrated by the fact that we can't deliver that consistently across our patch. So apologies we haven't had time to deal with the whole issue of prevention and recovery, but our pitch today, particularly recognising we have a largely acute sector audience here, is to say we can do an awful lot better in your hospitals if you allow us in there 24 hours a day to provide a consistent model.
Question on table number 10.
Hi, very nice model. Jackie Cornish, NHS England, National Clinical Director, Children, Young People, Mental Health a lot. So can you explicitly say, are you going to be integrating physical conditions into your mental health pathways?
Yes, and we've got some fantastic examples of that. One of the examples that we provide now, be careful what I say in relation to the previous presentation, but Birmingham and some of our partners started something called RAID, which is about rapid assessment and intervention in acute hospitals, which is absolutely putting mental health care alongside physical health care. And you can't believe how frustrating it is to actually have 2 massive investigations into it, demonstrating it saves money and is better for patients, and still have acute trusts and commissioners say, we don't want it. So yes, we are combined, and so some of our care pathways are mental health and for physical health. The bit we want to make the pitch here on, though, is about the consistency. We just don't have that consistency of provision across our patch, and the replicability of that is can we demonstrate that we can do that, and particularly for urban areas, can we then see that replicated across the country?
That's excellent, because you will know there is national support at the highest level for, as you mentioned, parity of esteem and the integration of physical and mental health. Thank you.
Thank you very much. That's the last, time's up for the questions. So can I have a big round of applause for the Mental Health Alliance for excellence, resilience, innovation and training.